Hello and good evening all.
Good evening.
Thank you for joining us this wonderful evening. I am Dr. Nobles Korea, today's host of this program. And this program was organized by Doctor of Pharmacy Association in collaboration with Apollo Athletics Hospital, Angamai, with utmost importance because antibiotic resistance is a global concern and the future of antibiotics depends on all of us. This coordinated intervention to improve rational use of antibiotics through an antibiotic stewardship program plays a pivotal role. So within the 6 days of notice period, we have more than 1,000 of attendees, and that's a great achievement for us. So let's not make any more time. Once again, thanking you audience for your time. And today's moderator of the section is Dr. Srilashmi. She is a clinical pharmacist in Apollo at Lex Hospital. Over to you, Dr. Srilashmi.
Thank you, Dr. Noble. I hope I look presentable and my voice is clear to all.
Yes, ma'am.
Okay. So hello, a warm good evening to all gathered here on this wonderful evening. So let me thank the audience first for taking the time to join us today. My name is Dr. Sri Lakshmi, working as a clinical pharmacist at Apollo Adlex Hospital, Angamali, and the moderator of today's session. Okay, let me start that I'm sure that you all might have heard about MRSA, methicillin-resistant Staphylococcus aureus, carbapenem-resistant Klebsiella pneumonia, carbapenem-resistant Acinetobacter, and the extended spectrum beta-lactam producing E. coli. So what are they and where these resistant organisms or strains of bacteria come from? So yes, we all have to think about it. And I think that a treatment of infections with a broad spectrum of antibiotics as empirical therapy is leading to this resistant type of strains. You know that 20% of the patient receiving antibiotics in hospitals is experiencing a ADE, that is adverse event, and we can protect them by improving the way we prescribe antibiotics. So it's all in our hand. So this webinar is all about antimicrobial stewardship and the program each hospital should concern taking a part. Yes, so I quickly welcome our beloved CEO, Sudarshan B, Apollo Adlex Hospital, who couldn't join us today for some reason. I welcome Dr. Shuhaib Khader, the Chief Operating Officer, Apollo Adlex Hospital, for the inaugural speech. We are delighted to have you, sir. Hello. Welcome, speaker. Inaugural. So now I welcome Dr. Ramesh Kumar, sir, Director of Medical Service, Apollo Adlex Hospital, for welcoming the gathering. Over to you, sir.
My beloved
members of the Doctor of Pharmacy Association, the respected delegates, our faculty for the day, Dr. Ravikiran, as well as Dr. Vishnu Nair, Medical Superlex Hospital, Dr. Saju, Samuel Jacob, Dr. Nobel Skaria, and Dr. C. Lakshmi, the moderator, and well, of course, all my dear friends. Good evening and a very warm welcome to this session on antimicrobial resistance hosted by Apollo Atlex Hospital in association with the Doctor of Pharmacy Association. And it's quite relevant that we are just having a session here on this antimicrobial resistance, because this is something which has been catching up with over the years, maybe last a decade or so. We have been working all those who have been concerned with all the stakeholders in medical fraternity or medical development have been concerned about the antimicrobial resistance over the years. What we were really facing was something called as a discovery voyage. Maybe we're down. There's something like the newer newer antibiotics. There is the drying in the pipeline, because nothing was waiting. Maybe a couple of decades back, could be around 1990s only, we had the last antibiotic, maybe colistin, and later I'm not sure what exactly, but then we didn't have much, only one or two antibiotics coming up in the last 2 decades. Maybe in 1945 we had Alexander Fleming coming up with penicillin, the beta-lactams, then the extended spectrum beta-lactams, the ESBLs, and then every time we have a newer antibiotic, the bugs are more wiser. They came out with something which can make it, neutralize it. They have what is a beta-lactamyces, extended spectrum beta-lactamyces, carbapenemyces. Everything was coming up in that. And even later on, we had the very virulent Delhi bugs, the what do you call is later on beta-actamyces, organ-producing organisms. So that was all something which has confounded the scientists and those who have been researching in this particular field. So, and we at all the organizations have been working on this, especially in Indian Academy of Pediatrics, where I was the national president a year and a secretary for another 2 years. We had this program running from 2014 onwards, where we called us AAA, Avoid Antibiotic Abuse, AAA. And later on, we put it as the Antimicrobial Resistance Program, and then the AMS, Antimicrobial Stewardship with WHO, was taken up in 2018. And later on onwards, almost every association or every stakeholder in this particular sector is concerned with the antimicrobial resistance. And we had a lot of, in every hospital, every institution, we had the AMS, the training programs coming up, more and more sensitization, more and more appraisal regarding the AMS, antimicrobial resistance. And we need to look, all of us, we should be more working together on this aspect, and there should be some some protocols and norms regarding the use of antibiotics. And well, of course, the clinicians and physicians are very much concerned about it. So it's high time we should make ourselves. We have got the MDRST, multi-drug resistance salmonella typhi, and later on we have got the MDR-TB now. Looking at is giving a very grim picture on the profile of the tuberculosis management. So MDR-TB. So everything, and people are. There are many situations where you are using and there's reserved drugs like the linezolidons, or even the vancomycins, or even the piperacillin, of course, and later on the vancomycins or imipenems, carbapenems, everything being used without much rationale. So there should be norms for coming up to each and everything. So, well, I'm so happy that the Apollo Clinical Pharmacy Division, headed by Dr. Noble and Dr. C. Lakshmi, of course, ably supported, and our management with Dr. Mr. Sudarshan as a CEO, and Dr. Shuhaib Kader, Associate Chief Operations Officer, Dr. Sarju, who is leading the clinical team. All of them have come out with this wonderful idea of hosting this webinar. And I believe this kind of webinars could be something of a periodic appraisal regarding antibiotics, or whatever you can have, update your information, recapping the basics and updating the advances. So that's all a good learning process, and knowledge is always wealth. And so definitely that insight is going to help you. So I am so happy, in the absence of our CEO, I am so happy to take the privilege of formally inaugurating this session too. So, and well, of course, I am not that visible. I'm traveling actually back. So that's a great session, and I will also be joining back maybe a couple of minutes later with you. But this will be, I wish, a very great and wonderful learning session for all my dear friends. And you all be the champions of antimicrobial stewardship in the future. You are champions, but you are improvising, or you are making more of your friends are champions of AMS in the future, creating more champions. Thank you very much, and wish you a very, very good an hour ahead, a very good time with learning. And I am happy to welcome the faculty for the day, Dr. Ravikiran, Dr. Vishnu Kumar, and all our Dr. Vishnu and all my dear friends. Thank you once again, and wishing a best time ahead. Thank you.
Thank you
Thank
so
you.
much. Thank you so much. Okay, so coming back to our webinar, you can expect our speakers to have their talk for about 30 minutes or so. And if you have any questions during the webinar, please type them into the chat window, and we'll address them during our Q&A session at the end of the webinar. Without further ado, and let me take the privilege to welcome Dr. Vishnu R Nair, presently working as an executive clinical pharmacist at Artemis Hospital, Gurgaon, and who has various achievements in the field of antimicrobial stewardship programs, and an excellent teacher who conveys his message in a simplest and easy way, or the format, so that everyone can catch it up. So welcome to the webinar, Dr. Vishnu R Nair. Over to you, and we are hoping for a very interesting class. Over to you.
Oh,
sorry, Dr.
yeah. Hello to all. I am Vishnu. Am I audible to you now?
Yes, you're on.
Yeah, actually, I forgot to unmute it. So, yeah. So, my name is Vishnu. I had finished my PharmD, and now I'm working as a clinical pharmacist in the Department of Infection Control, that is Antimicrobial Stewardship. So, basically, in this presentation, we will cover as much basics as possible due to time constraints, and considering the fact that AMS is a very big topic. Definitely, whatever basic things that you need to know will be covered in my presentation. So moving on to the same, I hope you have a amazing learning experience ahead. Can you see my presentation?
Yes, sir.
Yes,
sir.
Yeah, good. So this presentation is actually going to be a bit big. I tried to make it concise as much as possible, but when I was actually collecting information, I found that almost everything is very relevant. So somehow I summarized. So without wasting any time, let's go into the details. So as you know very well that antimicrobial stewardship is a tremendously huge concept. So in this presentation, I'll try to cover 4 major points. Why I said, because all these aspects are quite big. So I'll try to cover these 4 aspects. First is causes of antimicrobial resistance. What are the factors that need to be considered when selecting an antibiotic? And, this is a question which many people ask me, how to, remember antibiotics easily, or maybe its properties or whatever it is in an easy manner. So there is a single slide which will help you get an insight into. And just as a bonus, I have added some amazing facts regarding antibiotics as well. So these are the 4 topics that I will be covering. So let's go into it one by one. So this is something that I usually tell people, many people in profession and many people, many of you who are actually students right now, The common complaint that I always receive is we fail to remember things. So I believe that you should have the habit of making your own notes, because that is my personal experience. So when you make your own notes, your memory improves, definitely your handwriting improves. And if you are a student and you are, preparing for an exam, then definitely your writing speed will also improve. Your knowledge regarding the topic enhances, because whatever I have made in this slide, I have made my own notes and converted into PowerPoint. So I'll be able to explain it better. And definitely your presentation skills will also develop. So first, let's talk about what is antimicrobial resistance. So it can be antibiotic resistant. Mostly I'll be talking about antibiotics in this presentation, because antimicrobial means it's a huge concept. So when the maximum level of antibiotic that is tolerated by the host, so maximum level of antibiotic means it is a level beyond which side effects can happen. So when the maximum level of antibiotic that is tolerated by the host is not sufficient to stop bacterial growth, in that condition, we usually call it as bacterial resistance. Now, if you want, you can add fungus to it. So when the maximum level of antifungal tolerated by the host is insufficient to stop fungal growth, then you can call it as fungal resistance. Now, antibiotic resistance bacterial resistance is classified into two. One is called natural and the other is called acquired, or natural, which is also known as intrinsic, and acquired, we have relative and absolute. So natural resistance means it has not evolved over time, means it is not a slow process or something. Already there is resistance. You cannot do anything about it. So in this condition, the pathogens do not usually respond to an antibiotic. So for example, there are a lot of macrolides which are ineffective against almost 1/4 of Streptococcus pneumoniae. Now we come to acquired resistance. So acquired resistance is what antimicrobial stewardship is all about. Because when we use antibiotics indiscriminately, that is when acquired resistance come into existence. So in this condition, previously sensitive pathogen is no longer sensitive. So there is an example here. There is an organism known as Haemophilus influenza. So this is actually notorious for causing meningitis. So initially ampicillin was actually effective, but now there are many cases in which ampicillin is no longer effective against Haemophilus influenza. So that is acquired resistance. Now let's talk about the reasons of antimicrobial resistance. So it is broadly classified into two categories. One is microbial causes and the other is called, factors precipitating antimicrobial resistance. Why I differentiated it into both, because we need to understand what happens in the bacteria, and we also need to understand how much our involvement is also responsible for the same. So if you look at microbial causes, we have genetic alterations concept, we have altered target concept, we have reduced accumulation concept, and we have enzymatic inactivation concept. So we'll talk about that. So genetic alteration means very simple words. In bacteria, bacteria consist of a DNA, and with time, it undergoes mutation. And when there is mutation, it causes acquired antibiotic resistance. Very simple term. Altered target concept means due to the mutation that I explained before, the target site of the antibiotic can change. So normally an antibiotic binds to a particular site of the microorganism. Due to mutation, that underwent a change. So now that target site is no more valid. So this happens in the case of fluoroquinolone resistance. So there is an enzyme known as DNA gyrase, which is actually important for fluoroquinolone to show its mechanism of action. And if there is an alteration in this enzyme, it can cause resistance to fluoroquinolones. Reduced accumulation concept. First of all, you need to understand what is accumulation. Accumulation means collection of bacteria antibiotic concentration inside the organism, because sufficient concentration of antibiotic should enter the organism in order to show its mechanism of action. So how can a particular antibiotic lack its property to accumulate in an organism? So there are two reasons. First reason is reduced uptake. Reduced uptake means the antibiotic is not able to enter inside or not able to collect inside. And increased efflux. Efflux means from inside to outside. So bacteria consist of efflux pumps that helps in throwing the antibiotic outside. So these are the two reasons why, due to reduced accumulation concept, resistance occurs. So examples are written here. So gram-negative organisms, they undergo alteration in porine channels, so that limits the penetration of beta-lactam antibiotics. And initially, bacteroids were actually very, very sensitive to tetracyclines, and bacteroids are very notorious for gynecological infections. So usually tetracyclines were given for that. But now what happens is there is a resistance pattern in bacteroids in which efflux concept has been executed. That means through the efflux pump, tetracycline is being thrown out. So that is why there is a reason for tetracyclines being no longer effective against bacteroids. Now we come to enzymatic inactivation concept. It's a very simple. Enzymatic inactivation means there is an enzyme produced by the organism. That enzyme is breaking down or deactivating the molecule. Simple. So we have so many examples. We have mentioned main three enzymes. One is called beta-lactamase. You know very well. It breaks down the beta-lactam ring. That is why we use beta-lactamase inhibitors. Then we have acetyl transferases. So they inactivate chloramphenicol or aminoglycosides. And then we have esterases that cause resistance in macrolide antibiotics. So next we have our own causes, the factors which precipitate antimicrobial resistance. So the first reason is unjustifiable use of antibiotics. So this you know very well, I don't need to explain much. If you are using unnecessarily for a long time, if the dose is not sufficient, or maybe previously you were giving, or maybe you are using an antibiotic which was resistant. So there is a risk of cross resistance when you are having the same infection and trying to use the medication of the same class, and irrational use, all these things we know very well. So I don't think I need to explain much. Non-compliant self-medication and use of leftover antibiotics. Now, this is very, very important because there are, a lot of antibiotics that are given as OTC, maybe, and okay, even if it is, first of all, antibiotics should not be given as OTC in my view. And even if it is given as OTC, most of the people have the concept that if they are symptomatically better, then they don't need to complete the course of the antibiotic. So that is also equally dangerous. So if you are not taking antibiotic for the entire prescribed course, then the pathogenic bacteria with time get adjusted to the presence of low dose antibiotics. A population is formed in future, and next time when you get the same infection, it will not work. Then this is also important, we use in animal husbandry, aquaculture and agriculture. Antibiotics are used in that, either to prevent infections or maybe to increase the productivity. That is called increased produce. So if you are using it in uncontrollable fashion, then definitely it creates a reservoir of resistant antibiotics. So that can also lead to antimicrobial resistance. And definitely infection control is very, very important. Poor hand hygiene, you know very well, poor hospital hygiene and sanitation procedures. So all this can lead to outbreak of infections, and not only infections of the resistant type. Now let's talk about Antimicrobial Stewardship Program. We say it as AMS, so we have added program, so it is AMSP. So it's a formal body which deals with rational use of antimicrobials. So it's a common understanding between microbiologist, physician, and clinical pharmacist. And in order to remember the principles of antimicrobial stewardship, you can use this mnemonic 5 Ds. So 5 Ds means appropriate diagnosis. Unless you understand what the condition is, if whatever antibiotic you give, it doesn't make any sense. Unless you understand which is the appropriate drug for the patient, there is no point in talking about stewardship. Unless you give it at a particular dose or and the route of administration, all these things, unless it is optimal, there is no point in treatment. And if you are using it indiscriminately, that means you don't have any control on duration. Either you reduce it too much or you increase it too much. So if it is not optimal, then also there is no point in talking about AMS. And definitely de-escalation. De-escalation is an important term. De-escalation means you are moving from a higher antibiotic to a lower antibiotic. Like for example, patient was given maybe polymyxin B or colistin, which is a higher antibiotic given for gram-negative infections. And then the physician, the clinician, de-escalated it to meropenem or maybe ceftriaxone, which is of a lower generation. So it is always good that you de-escalate when the situation is favorable. Again, when the situation is favorable, depending on patient condition, culture reports, etc. Now let's talk, this is actually a big topic, factors influencing antibiotic selection. So we have 9 factors here. Identification of the organism, empiric antimicrobial therapy, susceptibility of an organism to a particular agent, site of infection, patient factors, targeted therapy, prophylactic therapy. If you have studied about rational use of antibiotics, especially by the WHO, they talk about empiric therapy, prophylactic therapy, and targeted therapy. And there are many people who are confused between empiric and prophylactic. They think that empiric and prophylactic are the same. So here I'm going to say how they are different. And definitely safety and efficacy of the antibiotic that you are using and cost of therapy. Identification of the infectious organism. So basically, how do you identify? Here, microbiology comes into place. So mainly we focus on gram staining, and gram staining is very, very popular, you know very well. And especially another benefit, actually I read a book and I found that it finds particular application in identifying the presence of microbes in body fluids that are normally sterile. So there are certain body fluids of us that are normally sterile. So there also, if there is an infectious pathogen, gram staining can help in identification of the same. So the examples have been, mentioned below: blood, CSF, urine, pleural fluid, synovial fluid, and peritoneal fluid. Now, this is actually a very controversial statement, but it's not exactly controversial because, we can say it as controversial because we have seen many scenarios in which the culture has been sent after antibiotic has been initiated. But according to the rule, we usually send specimens for culture before starting the first dose of antibiotic. The reason is that if the antibiotic is started before cultures are sent, there can be a chance that the culture may come out sterile. Now, if the culture comes out sterile, we cannot say whether it is because of the absence of organism in the first place or whether it is because the antibiotic that you gave beforehand helped in killing the organism. Now, for example, you have given ceftriaxone to a patient and for maybe 2 or 3 days or something, and after that you thought of sending the culture, and the culture report comes out sterile. Now you cannot say whether actually it was sterile in the first place or it is because ceftriaxone killed the infecting organism. So usually we should send specimens before starting antibiotic, but there are certain special scenarios in which you do not have time to wait for the culture report to arrive and then, culture report to be sent and then start. So I'll talk about that in future slides. Now let's talk about empiric antimicrobial therapy. So first, let's talk about spectrum. Whenever you read books about maybe antibiotic books, they always talk about spectrum. So spectrum is actually defined as a range of microorganisms that respond to an antibiotic. So this is actually the basis of empiric therapy. So empiric therapy means a patient is admitted in the hospital, the clinician is suspecting an infection, but we don't know what the infection is. So when the cultures are being sent, the clinician is initiating an antibiotic which may cover suspecting or maybe suspicious organisms. So that is called empiric therapy. But we must always remember that in vitro susceptibility doesn't guarantee in vivo efficacy. That means sometimes what happens is there are certain scenarios in which the culture report is showing that a particular antibiotic is sensitive. But when the same antibiotic has been initiated in the patient was not improving well. Or maybe there was no significant improvement in the patient. So this is just a generalized perspective. We have to look into individual patient case scenarios and then determine which is the choice of antibiotic to be given. So this is actually a special case. Like for example, in a critically ill patient, delay in administering antibiotic could be fatal. So that is why in those conditions, you have to give immediate empiric therapy. So we usually focus on broad spectrum antibiotics, especially in critically ill patients. The empiric therapy, as per the rule, should be substituted with narrow spectrum antibiotic. That means it's a kind of de-escalation. As I said before, de-escalation. The empiric therapy should be substituted with either targeted therapy. That means after the culture report comes positive, we are giving the antibiotic. So that is called targeted therapy. Or we should de-escalate it within 48 to 72 hours as per culture and sensitivity report. So now let's talk about, obviously the factors influencing empiric therapy is the timing and drug selection. So these are the two factors which determine empiric therapy rationality. So timing, as I said before, usually in normal cases, before starting the first dose of antibiotic, we should be sending the cultures. But these are certain scenarios in which we don't have time to look into that, especially even if it is a septic shock patient also, we don't have time to look into that. So the following patients require immediate empiric treatment. One is a neutropenic patient. So neutropenic patient means neutrophil level is very low. So the patient is at a very high risk of bacterial as well as fungal infections. And definitely a patient with symptoms of meningitis. So in such patients, cultures may be sent after administration of antimicrobials or antibiotics, whatever it is. Now let's come to the drug selection. So what drug should be given empirically? So it depends on the site of infection. It depends on patient history. That is why, whenever if you are working in the stewardship program, patient history is also very, very important. Like for example, what happened is I encountered a case in which the patient has been directly being given meropenem empirically. The culture had been sent though. So when I actually look at the patient history, 14 days before, the patient was admitted in the same hospital with an infection, with an UTI, and it was ESBL. That means Klebsiella pneumoniae was found, which was ESBL. And the patient actually got discharged by his own. That means left against medical advice. So that is why when the patient got again readmitted due to severity of his condition, meropenem was being given. Then the cultures were sent, but then the urine culture came out sterile. So meropenem was gradually de-escalated. So the patient history is very, very important. Travel history, you know very well. We get a lot of infectious diseases based on our travel history. Definitely on your immune status, recent history of antibiotic use. So basically, we focus on broad spectrum antibiotics. It can be third or fourth generation cephalosporins, maybe doxycycline and fluoroquinolone. When the organism is unknown or when polymicrobial infections may be suspected. So in those conditions, we give broad spectrum antimicrobial. But again, it is the choice of the clinician. Let's talk about the site of infection. So, usually when we give an antibiotic, it does not create much of an issue. But sometimes what happens, there are certain natural barriers in our body. And in those areas, if antibiotic is given, it may not be able to show its activity. So these are some natural barriers that have been mentioned here. And the most important is the CNS, because it is called blood-brain barrier. So all antimicrobials cannot cross the blood-brain barrier and enter into the CNS. So there are some factors that determine which antibiotics can enter into the CNS. So there are 4 factors. We'll come into that. So if you look at the factors that influence the penetration and concentration of an agent in the CNS, first is lipophilicity or lipid solubility. So here I have mentioned direct proportionality because I don't want to explain in big words. You may have understood what I meant with that. As the lipophilicity increases, the penetration of the antimicrobial into the CNS increases. So some examples I've mentioned here, chloramphenicol, metronidazole, they are highly lipophilic molecules. The remaining 2 I have mentioned as inverse proportionality. So if the molecular weight of an antibiotic is huge, then there will be difficulty in crossing the BBB. And if the plasma protein binding is huge, then also the chances of crossing the BBB will be less. Then we look into patient factors. So patient factors also need to be considered. This is called individualization of treatment regimen. So you need to look into patient factors as well. The first factor is immune status. So in immunocompromised patients, you know very well, high doses of bactericidal agents or maybe for long period might be required. So these are some examples of immunocompromised patients. So if a person is chronic alcoholic, the person is immunocompromised. Malnutrition, you know very well. HIV infection is also, you know very well. Autoimmune diseases. Why autoimmune diseases? Autoimmunity means your body's immune system is considering your body as enemy and it is sending antibodies towards it. So usually the treatment of autoimmune diseases means you use immunosuppressants. And immunosuppressants mechanism, very simple, it reduces your immunity. So this kind of patients are also at high risk of immunocompromisation and getting infections, and definitely advanced stage that we know very well. Then let's talk about renal damage or renal dysfunction. So if your kidney function is very poor, then it can cause accumulation of antibiotics whose mode of elimination is renal. That means they get eliminated through urine. So when your kidney function is poor, the elimination doesn't happen and they get accumulated inside the body. So that can lead to toxicities. For example, aminoglycosides, colistin, polymyxin B, vancomycin, amphotericin B. If you talk about hepatic dysfunction, antibiotics that are concentrated or eliminated by the liver. For example, erythromycin, doxycycline, cotrimoxazole, or chloramphenicol should be carefully used in patients with liver dysfunction. Now, there are a lot of things that can be mentioned here, since, as I mentioned before, due to time constraints, maybe in future webinars or something, we can talk about all of this in detail, depending on situation. So now let's talk about poor perfusion. Now, this is usually applicable to patients who are suffering from diabetic foot, a diabetic foot infection, because you know very well in diabetic foot infection, the blood supply to the lower limbs is restricted. So perfusion means blood flow. If there is reduced circulation to a particular area, then the antibiotic may not be able to reach there and show its activity properly. So it can be less efficacious. Now, if you look into the age, so we have 2 extreme ages that I have mentioned here. One is newborns and the other is elderly patients. In newborns, the renal or hepatic elimination process is very poor. So there is a high risk of toxicity. That is why we usually focus on specific dosings for pediatrics. avoid tetracyclines or quinolones in young children. If my information is not wrong, if my knowledge is not wrong, then I believe that tetracycline should not be used below the age of 8 because it affects bone growth. And as far as quinolones is concerned, it can affect your joints. In elderly patients, renal or liver function may be compromised, so that can also affect the way antibiotics work in them. And obviously, pregnancy and lactation, it's very simply understood. If a particular antibiotic is crossing the placental barrier and entering into the, reaching the fetus, then it can cause congenital problems. Like, for example, if tetracyclines are used in pregnancy, then the child may be born with tooth problems or maybe bone defects. And like that, fluoroquinolones also, if my knowledge is correct, should not be used in pregnancy. Now let's talk about targeted therapy. So before I said about empiric, so I just mentioned some steps in which you can understand what targeted therapy is all about. The patient is admitted to hospital for some condition. The clinician is suspecting infectious involvement. So the antibiotic is started empirically. The cultures are sent accordingly based on suspicion of site of infection. So it can be a blood culture, it can be urine culture, it can be ET. ET means endotracheal, BAL means bronchoalveolar lavage, stool, body fluid, whatever it is. If the culture report comes out as positive for a particular organism, based on the sensitivity or resistance pattern, antimicrobial is initiated. So, such a scenario in which empiric therapy is switched over to an antimicrobial that works against definitive organism. That means you are switching from empiric to targeted. So that is called targeted therapy. And in some books, we can find it as definitive therapy also. So this is just an example. I'm not sure as in how much this will be clear for you. This is actually a culture report. And the patient was admitted. Meropenem was actually given empirically. And ET culture was actually sent. As I said, ET is endotracheal. The culture came positive for Klebsiella pneumoniae, which is resistant to meropenem. Actually, this culture report is very big, but I've only shared a snapshot of the first page. So if you look at the last, you can see ertapenem resistant. And after that, meropenem, imipenem, all these things are also resistant. So meropenem was stopped, which was empirical, and it was switched over to a targeted therapy, that is ceftriaxone EDTA sulbactam. You can see there, ceftriaxone EDTA sulbactam is sensitive. So this is an example of targeted therapy. Now let's talk about prophylactic. As I said before, we all get confused between empiric and prophylactic. We usually interconvert the terms. So the skin usually consists of numerous organisms, mainly Staphylococcus, but we have other organisms also. So when a particular patient is undergoing a surgery or a dental procedure, there is a chance of these organisms to enter into our body and cause serious infections. So in order to prevent such occurrences, antibiotic is usually given as surgical prophylaxis. So this kind of therapy is known as surgical antibiotic prophylaxis also, SAP. In some areas we say it as SAP also, surgical antibiotic prophylaxis. So in normal case, a single dose of an antibiotic maybe can be given 60 to 120 minutes before the infusion, 1 to 2 hours before the infusion, depending on the antibiotic. And usually what I have seen, and it is usually found in many areas, that although a particular antibiotic was intended to be surgical prophylaxis, it is still continued after that for many days. So when we usually ask why it is so, then they have their own reason. So if a particular antibiotic that has been given as surgical prophylaxis is being continued post-operatively, then definitely there should be a documented reason behind the same. Because if we are using indiscriminately post-operative antibiotics, you know very well, it can lead to bacterial resistance and superinfection. Superinfection means the healthy flora in our body can also get eliminated based on the spectrum of the antibiotic. So that can lead to infectious organisms to enter into our body and cause diarrhea and all this kind of things. Now let's talk about the last option, about cost of therapy. Many antibiotics show similar efficacy, but when it comes to the cost, there is a differentiation. So this is just an example. I took a snapshot of a book. It is Staphylococcus aureus, and cefazolin usually nowadays it's not very sensitive, but still I just thought that I'll share it with you. All these antibiotics are effective against Staph aureus. But if you look at the cost, you can see the drastic change, especially when it comes to linezolid and daptomycin. So we can select an antibiotic for the patient, but we need to look into the cost as well. Then we talk about determination of antimicrobial susceptibility and rationality. So these are certain terms that you need to know, especially if you are a working professional or even if you are a student, maybe you're part of hospital duties. Minimum inhibitory concentration, minimum bactericidal concentration, CDK, TDK, and PAE, post-antibiotic effect. So usually in clinical scenarios, we use MIC. Actually, MBC is also good, but the problem with MBC is that microbiologists will know it very well, that, you know, a lot of time and labor and, you know, specific equipment is required for the same. So usually we don't use MBC. We usually focus on MIC. So MIC is the lowest antimicrobial concentration that prevents microbial growth. That means inhibits means prevents after 24 hours of incubation. And MBC means bactericidal. You know very well, bactericidal means it kills the organism. So the growth in the particular means the colony, number of colony counts in the sample will be reduced. But usually, as I said, we don't use MBC in clinical practice that much. Now let's talk about concentration dependent killing. Now, concentration dependent means if you increase the concentration of the antibiotic, or maybe if you are, you know, depending on the MIC. So MIC means in the culture report, when the culture report comes positive for an organism, usually you will see MIC values written below. So concentration dependent killing means if you are increasing the dose, or maybe you are increasing the concentration of an antibiotic, maybe 4 times or to almost 64 times the MIC, then the rate of bacterial killing increases. So maybe such drugs can be given as once a day bolus that helps in attaining high peak levels, that means concentration, and it can kill the infecting organism rapidly. So we can, for example, aminoglycosides and daptomycin. So these are 2 examples. I took just snapshots. So here you can see tobramycin and piperacillin. Tobramycin, as I said, it undergoes concentration dependent killing. So if you see in the graph, you can understand very well that as the concentration increased, as we increase the concentration, that is 64 MIC, almost 64 MIC, then the rate of bacterial killing increased. But obviously, you cannot simply increase the concentration. You have to look at the safety profile also. This is just a generalized perspective. But on the other side, if you look at piperacillin, there is no significant change. You can see that all the MICs are coming almost streamlined on the same, almost like adjacent to each other. So that's the difference. Time-dependent killing is exactly the opposite of concentration-dependent killing. So in this condition, we usually focus on percentage of time that blood concentrations of a drug remains above MIC. So what is the time duration? We are looking here at the time duration. So in this cases, you can focus on extended or continuous infusions. So maybe you can achieve a prolonged time above the MIC to kill the organism. Examples: beta-lactams, glycopeptide antibiotics, macrolides, clindamycin, and linezolid. Post-antibiotic effect. So it's like, even if the antibiotic level is below MIC, there are certain antibiotics that keep on showing its activity. So that is a very big advantage actually. Always when we try to keep it above MIC, you have to look at the safety issue also. But there are certain antibiotics that even if the concentration goes below the MIC, they are still efficacious. So such drugs require just 1 dose per day. Examples, aminoglycosides and fluoroquinolones. Now, 1 dose per day is like, is a generalized perspective. It depends on the potency of individual aminoglycoside or fluoroquinolone. Just said it generally. Now, how to study antibiotics easily? Now, basically, this is a question that I get from many people. They always get confused whether they are students or maybe, always get confused. So I always say that, unless and until you understand the function of your body, you will never understand what happens when a disease affects your body. Like, for example, if you don't know human anatomy and physiology, then definitely you will never understand how pathology works. And if you don't understand how pathology works, then you will not understand how to give rational therapy for that particular pathology. Similarly, microbiology is the base. What happens is we directly start studying about antibiotics, mechanism of action, kinetics, everything. But because recently I saw a case in which the culture came positive for Burkholderia cepacia. Now, Burkholderia cepacia is actually a gram-negative organism, and vancomycin was being given for that. And I was like surprised, because vancomycin usually targets gram-positive, and Burkholderia is gram-negative. So, and definitely that was an incident which prompted me to make this slide. And also many people have difficulty in remembering. So I always say that you start from the base, and definitely as your hospital duties and your interactions with other healthcare professionals and your personal learning improves, then definitely you can progress. At the end of the day, we all don't know anything. We are all almost like, upgrading ourselves each day with something little by little. So this is the last aspect. It's regarding some amazing facts regarding antimicrobials. Some just random things that I just put into. So I just thought I'll share it with you. So these are some medically important bacteria, not fungus. So just medically important microorganisms. This actually I took a snapshot from Lippincott's Pharmacology Reviews. It's a book that I personally suggest people to read because it's very easy to understand. So medically important microorganisms, the names have been mentioned here. Gram-positive cocci, GPC, gram-positive bacilli, GPB, gram-negative cocci, gram-negative rods, anaerobes, spirochaetes, kind of mycoplasma, chlamydia. These are the main, pathological organisms that we usually encounter in practice. Now, usually, whenever we study about antibiotics in pharmacology, or maybe, normal conditions also, we talk about narrow spectrum, broad spectrum antibiotics. So narrow spectrum, the example is mentioned here. If you look very closely, lot of other organisms names have also been mentioned here, but they are blurred because isoniazid is not effective against them. But the one which is actually boldened, isoniazid is effective. That means it's only active against mycobacteria, nothing else. So this is an example of narrow spectrum antibiotic. Let's come to extended spectrum. So it has activity against gram-positive and gram-negative also. Very good. So we have ampicillin effective against maybe, gram-positive, cocci, gram-positive bacilli. Again, here Haemophilus influenza is mentioned, but there are very few cases in which actually ampicillin is sensitive, still sensitive, or maybe still working against Haemophilus influenza. It is a part of acquired resistance. So ampicillin is effective against gram-positive and gram-negative as well. Then we come to broad spectrum. These are the most beneficial, and at the same time, these are the most dangerous also. Broad spectrum means they are effective against a variety of organisms. So that is a good news. But the bad news is when they are effective against a variety of organisms, they can also attack the healthy organisms in our body. So they can lead to life-threatening infections like Clostridioides difficile diarrhea. It's very, very commonly seen with broad spectrum antibiotics. So here is an example of tetracycline, which is a broad spectrum. This is actually I had made a presentation on aminoglycosides. So I just took a slide from there to share it with you. This is paromomycin. This is a newer aminoglycoside. And why I attach it here is because this is the only aminoglycoside. This is actually having anthelmintic property. That means it's effective against worms. Now, this is very, very interesting because usually aminoglycosides, if you look at spectrum of activity, mainly gram-negative organisms. So that is referred to bacteria. But pyromomycin, you can just check it out, is effective against worms. So you can see the examples: Entamoeba histolytica, it's a protozoa, Cryptosporidium, Taenia species, etc. So it is used in intestinal amoebiasis, cutaneous leishmaniasis, etc. And this is about empirical therapy. So the choice now, how to select a particular antibiotic. So that can also depend on the association of organism in a given clinical setting. So for example, if it is a newborn, and if gram-positive cocci is suspected in the spinal fluid, then it can be most likely to be Streptococcus agalactiae. So it's a group B streptococci. In majority of scenarios, it is effective or it is sensitive to penicillin G. So there we can use penicillin G. But if it is a 40-year-old patient, and if we look at the spinal fluid, there are chances that it can be Streptococcus pneumoniae, which is resistant to penicillin G. So in that condition, penicillin G will not work. We usually focus on maybe high-dose third-generation cephalosporin, that is ceftriaxone, or maybe vancomycin. And this is an amazing fact about linezolid. Linezolid, you know very well, it is oxazolidinone antibiotic. And there is another molecule of the same class that has been approved recently, that is tedizolid phosphate. And I think another molecule is undergoing clinical trials. So whether it's been approved, I'm not very sure. It's called sutezolid for tuberculosis. Now, the property of linezolid is that it has both bacteriostatic and bactericidal property. So it depends on the organism. It has bacteriostatic property against Staph aureus and enterococci, and bactericidal property against most strains of Streptococcus pneumoniae. So this is an interesting aspect of linezolid. So basically in this presentation, as I said, this is a very huge presentation, and AMS is a very huge concept. So likely I could not cover most of the aspects, because if I keep on talking, you will get ultra saturated. So my point was just to give you an awareness, as in how AMS, how you need to, approach AMS in a practical way. And I hope this presentation is informative to you. Definitely the slides will be shared to you based on your demand. Thank you so much for listening to me. God bless you.
Thank you so much, Dr. Vishnu. Your slides were very helpful and interesting too. We are very grateful for the time and effort you took to share your thoughts. Now, let me take the opportunity to welcome Dr. Ravikiran Barigala, MBBS, MD in Infectious Disease and Internal Medicine, with more than 20 years of experience at various hospitals across USA, and now presently working as infectious disease consultant at Apollo Hospital, Hyderabad. He also was a teaching instructor at Medversity, Hyderabad, and Apollo Institute of Medical Sciences and Research. He is an active member at Clinical Infectious Disease Society of America and also Infectious Disease Society of India. So without consuming any time, I invite Dr. Ravikiran to enlighten us with his words of true wisdom. Over to you, sir. Sir, kindly unmute.
Sorry. So thank you for inviting me again. And thank you, Nabil. Thank you, Sri Lakshmi, for the introduction. So my format is going to be very different from Vishnu's format. Vishnu was more academic lecture style. which is great. But I'm sure you're a little tired and I want a little bit interaction and people to awake a little bit. I will be speaking about some cases. So we will be discussing about 6-7 cases. I don't know how many cases we will be actually be able to go through. I'll try to cut it short. And this is more of an interactive thing. And if you can put in your message in the chat box, that would be great. I'll be asking questions in terms of options, so you can respond to that. So hopefully it will go well, and then you'll learn some things. And after the case, then I will share why is this what we are doing. Let me share my screen. Okay. Everybody can see, I hope. And I will start talking then. Okay. So we will be talking about several cases, as I mentioned. Just a brief talk. This is going to be my outline for today: introduction, some cases, discussion, summary, Q&A at the end. As Vishnu mentioned, right? Every time there is an antibiotic that comes up, within a few days, what happens? It goes away. It gets resistant. And we're still using some of those, but they're not as strong anymore. It's lots of resistance has built up now. So we don't use it as much, right? What is antimicrobial stewardship? He talked a lot about it. So I will not go into it much. These are some of the components of an antibiotic stewardship program. The main thing is about having good leadership, accountability, people who know the drugs, having some action plan, monitoring, reporting, tracking, and education. So with that, I'm going to go into the cases. Okay, I'm sure you can see the cases here. So we have a 57-year-old lady who has uncontrolled diabetes, and her HbA1c is 11.6, which shows that her sugars are really bad. And she's getting recurrent UTIs. Multiple antibiotics have been used in the past. Now she's complaining of urine frequency, urgent, incomplete voiding. She also has some fever, chills, and back pain. Okay. So you got the picture. These are her vitals. Her heart rate is 124. Blood pressure is 90/50. Saturation is 95%. Her labs show WBC count of 17. Creatinine is slightly raised at 1.7, slightly low potassium. CUE shows 10 to 15 pus cells with some epithelial cells. Ultrasound also shows a bulky right kidney, and that's where she was complaining of some pain, right? What is your empiric choice of antibiotic now? So, responses, please. So a lot of people are saying Miro, Arta, Cipro. Mostly I got Miro, Cipro. Some people said colistin and cephalosporin sulbactam. So this is good. This is good. Okay, you guys are great. So let me see what my thought is. You want to see my thought? Meropenem is also my thought. So why would you choose meropenem? Because there are a few reasons here. This patient is uncontrolled diabetic. She's getting recurrent UTIs. She's used multiple antibiotics and she's having a UTI, not just UTI, she's also complaining of some back pain. And the ultrasound shows her right-sided kidney, her WBC count is high, her creatinine has gone up, vitals show that her blood pressure is down. So she's really in sepsis right now. Okay, we have to really try to target the right bacteria as much as possible. So that is why we're going to use meropenem. Okay, why not something else? Okay, so we'll try to get into that. So colistin is probably good. Also, it would probably cover it, but it's also nephrotoxic, and it may be too much for her. Why not ertapenem? Ertapenem may miss out on Pseudomonas. Why not ceftazidime sulbactam? Few of you said ceftazidime sulbactam, right? Of course, but she's had multiple antibiotic use, and we are seeing a lot of resistance now. So that may not work. At least 50% chance that it may not work for somebody who's used multiple antibiotics in the past. Cipro is hardly going to work. She's had so many antibiotic use, probably 90% chance that it is not going to work. And also she is in septic shock. In septic shock, even if you think it is going to work, really do not use it. It's a very weak drug. And also if she's got pyelonephritis, for that reason also, Cipro is not a great drug. Okay. So somebody says meropenem for UTI is amazing. It is amazing. It has got good penetration into the tissues. Vishnu was just talking about the penetration into all different types of stuff. And yeah, meropenem enters the tissues very well. So that's what we're going to do. Okay. Colistin may be unnecessary. This is my logic. I just mentioned that. Okay. So hopefully we'll be done with my things fast, and we'll be done with our lectures fast. But it all depends upon your participation. Okay. So we have an elderly 75-year-old male who had a colon cancer. So by the way, all of my cases are real cases, real world cases, which I have seen in probably in the last 2 months or so. Okay. So here we have a 75-year-old male who has got a colon cancer, who had a surgery about 10 days prior to when I had seen him. Also, he's diabetic, he's got some chronic kidney disease, he's got some heart problems. And he came in now after the surgery. He's now complaining of fever, abdominal pain, and weakness. On the labs, it shows WBC count is really high, 25. Creatinine is 1.8, it's slightly higher than his baseline. Albumin is very low because he is not eating. He just had a surgery. His vital signs shows his fever is okay right now, but he's having fever at other times. Blood pressure is also okay. Heart rate is okay. Oxygen saturation is also okay. Okay. Everything is okay. Ultrasound now shows actually an 8 by 5 centimeter collection in the right paracolic area, which means in this right, just below the liver, the right side of your body. It's a big, like this much collection there. Looks like pus. And we put in a needle and it actually drained pus, like really pus. What did the pus culture show? The pus culture showed an MDR E. coli, which means a multi-drug resistant E. coli, which is very resistant. It's a bad one, okay? Just like Vishnu showed something earlier, it's resistant to all. This is kind of like that. It's resistant to all. It's sensitive only to tigecycline, intermediate to colistin, resistant now to meropenem, imipenem, ceftazidime sulbactam, and amikacin. So earlier we had a meropenem sensitive one. Now we have a meropenem and even imipenem and aminoglycoside, ceftazidime sulbactam, all with resistant. Even colistin is only intermediate. It is sensitive to tigecycline. What antibiotic are you going to choose? So this is the time for you. Please don't speak anything. Just put in the number or type in the thing. Somebody says nothing. Somebody says TG, poly B, colistin, TG. Somebody wants to see the question one more time. Okay, I'll show you the question one more time. A 75-year-old with an intra-abdominal abscess, high creat, high TLC, low albumin, sensitive to TG, intermediate to colistin. What do you want to do? So we've had about 20 responses or so. Source control, then antibiotics, polymyxins, TG, polymyxins, TG, polymyxin, colistin, TG, poly B and TG. Somebody wants to give both. Okay, that's not an option for you. I only gave you one option that you could choose. You cannot choose both. Okay, so What do you think? Poly B, Poly B, Poly B. A lot of people like Poly B. I don't know why Poly B you all like. Let me share my thoughts. So my thought is TG. Why TG? Why not colistin? Why not Poly B? And why not nothing? First of all, patient is not doing well, right? Patient has been having fever. He's not septic, but he's having fever. His WBC count is 25. If you do nothing, he's just going to die. Okay, please don't tell people. Okay, what about colistin and polymyxin? So, it is also okay, but that colistin and polymyxin are more nephrotoxic and neurotoxic. So why would you want to use something else? Tigecycline is a good antibiotic. Okay, we just talked about a broad spectrum antibiotic, and this is one of the broadest spectrum antibiotics. It's going to kill everything, and it got a good penetration. It's only approved for 2 things. Okay, so better use in those situations. What is it? Intra-abdominal abscesses and skin and soft tissue, and also for community acquired pneumonia, but we don't really care about that. So these are the indications. So you got the perfect setup. You got a patient who's elderly, who's got high creatinine. This is the time to start teaching. But the case continues. Okay. Do you like the case? The case continues. Patient is not better. Now you actually have done CT scan. Earlier you had done ultrasound. Ultrasound, do you remember the size? 8x5. Now you have 9x6. So it's slightly bigger. Maybe it is just the ultrasound versus CT, but it shows it's slightly bigger. And patient is not feeling better. He's still having fever, still complaining of abdominal pain and all that. Okay. So what do? You have options. You always have options in life, right? What to do now? Do you want to aspirate again? It's another 10, 20 ml. Do you want to put in a pigtail? Do you want to add colistin, or do you want to send him for surgery? So your time kind of starts now. A lot of people keep asking about the certificates. I don't know why everybody is asking for certificates. Certificates will be provided. Okay. Point is not about certificates. Point is about learning. So a lot of people want to add colistin. Some people want to aspirate. I don't know which one is winning, colistin or aspiration. Colistin, aspiration. Any other people want to respond? Some of the quiet backbenchers types who just have locked in just to get a certificate. If you can wake up. Surgery, somebody wants to do surgery. So what is a pigtail? A pigtail means it is not a tail of a pig, please. Okay. The pigtail means a catheter, which just means a drain, actually. It's a small catheter. You know, have you seen a pig? And you know, you have a pony. You have a ponytail, right? And ponytail is big. Pigtail is really thin and short. It's like a kind of curve. So you put into the abscess. That's called a pigtail. Okay. Maybe you don't like pigs, so you don't like that term. Somebody says A plus C. Come on. Who's that? A plus C. Don't use 2 things. Muhammad Ajmal, you can only use 1. You cannot use 2. Okay. My response, should I show? Should I show? Sure. Pigtail. And that's why I spoke more about pigtail. Sorry to disappoint all the aspirations and colistin peoples. The answer is pigtail. That's why I told you a lot about the pigtails. What is a pigtail? Pigtail is a small catheter which you put in and then you have to drain it. It's always source control. If you're not controlling the source, we're always going to be in trouble. No matter what antibiotics going to whatever antibiotics you're going to use, it's not going to work very well because the source is the problem. Whenever there's an abscess, there's a cardinal rule is to try to take out the abscess as much as possible. The safest way to do it is aspiration. But when they aspirated, you got only 20 ml. It's got this much, that's got like almost half a liter at least. And you just got 20 ml. So that means it is either loculated or it's very thick or something else. Here's the reason that you're unable to aspirate. So what do you do in those cases? You put in a pigtail so that maybe it will all come out. It's a larger bore. It's usually about 2 to 3 millimeters or something inside rather than just a needle, which is just less than a millimeter. So that would be my thought. Yeah. So I would continue the tigecycline and put in a pigtail. That's what I did. But so why not repeat surgery? I think 1 or 2 people said surgery because the patient just had a surgery. Okay. And adding another antibiotic without controlling the source will fail. Case is still not done. You think it was done, but it is not done. Okay. This is like, a Hindi movie which twists, maybe a Malayalam movie. I don't know. After 7 days, the pigtail has been put in. He's still not better. And now the CT scan shows actually there is a collection with a bowel leak, which means there is some contents of the bowels. The large intestines is leaking, and that's why there is a collection there. So what? Now you cannot just keep quiet. Now there's a leak. You have to take for surgery. And then the repeat culture now shows a multi-drug resistant E. coli. Same E. coli, which was sensitive before, now it's become tigecycline resistant. It's not going to work. TG is gone. Now it is intermediate to colistin and resistant to everything else that we talked about. What do? You have 5 options. Always options in life, right? What do? You increase the tigecycline dose. Okay. You switch to colistin. You switch to fosfomycin, or it's a brand new thing in the market called ceftazidime avibactam. You switch to that, or no antibiotics are necessary because the surgeons, they're very confident. Any surgeons here today, don't mean to offend you, but they sometimes are very confident or too confident that they've done a great job and they think nothing else is required. We've taken care of. So we are getting answers. Phospho, ceftazidime avibactam, colistin, no antibiotics. Oh, somebody is really brave and says no antibiotics. Okay. Anybody else? All those sleepers? Did you wake up? Drain. Drain is not an option here. I don't know who's saying drain. D. Everybody likes this ceftazidime avibactam. It's a new thing. It's actually been there for quite a while, but the patent has expired, so a lot more companies have come out with this product now. Earlier there was only one company, now several companies are there. So what do you think? Okay. Okay, so let's see what I think. You want to see what I think? Switch to colistin because tigecycline is not going to work. If it is resistant, it's resistant. There's no point in continuing a resistant antibiotic. Better stop it. And that we know that it is intermediate. So that's one point also that I want you to learn, that even though it says it is intermediate to colistin, actually means it will work. The cutoffs for sensitive, intermediate, and resistant, the CLSI is the organization which does those cutoffs. They've removed the sensitive one. So it's only now intermediate and resistant. Because of that, even if it says intermediate, actually it probably is sensitive. So, and it probably will work. So and along with that, they have cleaned up. So it is probably a decent choice. Okay. Fosfomycin, why not fosfomycin or ceftazidime avibactam? Because they are not confirmed to be sensitive. A lot of people get very excited about these new molecules. Fosfomycin is not even new at all. It's been there for a while, but it actually easily gets resistance. We have a lot of resistance to both of them already, to almost 30 to even 50% resistance to both of them now. So I wouldn't necessarily use it without checking. versus the colistin resistance still is about less than 1%. So that would be a better way of going about rather than just changing to an antibiotic, which you don't know the sensitivities yet. So you have to control whatever is the problem, the source. Without that, then nothing will work. Adding antibiotics is not going to work. Okay. Third case, 58-year-old. So slightly older guy, not fully old. Okay. He's not 60 plus. 58-year-old, diabetes, hypertension, CKD. He's on dialysis for the past 2 years. And now he's come in because of shortness of breath, some fever, cough, weakness. And he's having a lot of fever, mainly fever during dialysis. And he's getting a dialysis through a catheter. And because he's got a fistula, they put the fistula on the arm and that failed and it's not working anymore. So what you're going to do? His vitals show he's got a fever, 101, heart rate is high, BP is slightly low, saturation is also slightly low, TLC is pretty high, 23s. Creat is high because he's CKD, potassium is also high, checks X-ray shows some pulmonary edema. He's got on a 2D echo, he's got a vegetation. Vegetation does not mean a plant, okay? Please, I hope you understand. Vegetation means what? Vegetation means an infection which is on the valve, on the aortic valve. So you've got a bad vegetation now. Okay. So he's got endocarditis and the blood culture has shown Klebsiella. And it is sensitive to meropenem, imipenem, digicycline, ceftazimab, intermediate to colistin, and it is resistant to everything else, which is amikacin, gentamicin, ceftriaxone, ciprobactrim, ceftazidime. That's the situation. So it is a slightly resistant type of bacteria, and it's an endocarditis. What would you do? So this, again, you have to think through this question well. Endocarditis in a dialysis patient with multiple problems, what will you do? So what dose will you choose? Meropenem, high dose, 2 grams TID, imipenem, 500 4 times a day, or meropenem 1 gram once a day, ceftazimab, or tigecycline. And actually told you that the ceftazimab is sensitive, even TG is sensitive. What would you do? Responses, please. A, C, D, A, C, D, 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 E, C. Imipenem because multiple infections, high dose meropenem. C, not sure of the dose. Well, that's why I'm asking. So this is as much as a choice, but it's also a dose question. You have to think through those. C is creatinine high. Okay, good. So we will go with this. Some people got it right. Some people did not think through it well. So as I said, it is a dosing issue. So first of all, meropenem is the right choice, but you don't give a very high dose because the high dose is going to be a problem. Why? Because the patient is on dialysis. Such a high dose is probably going to cause seizures. So don't give such bad dosing. Okay. What about other options? Imipenem, also high dose. Ceftazimab, also high dose. Tigecycline really should not be used. Don't you remember just now? I just said, do not use tigecycline in all other conditions except for skin and soft tissue, intraabdominal abscesses, or community acquired pneumonia. Only 3. Otherwise, don't use it. Okay. And it's also a very static drug. It should not really be used in endocarditis or bacteremia. So you have to really understand what is the correct dosing. You have to adjust, and dose should always be given after dialysis. And if you give too high of a dose, it's going to cause more problems. Okay, the case is not done because the case is exciting. You are giving meropenem, but patient is still having fever. What happened? The dose was low or what happened? Especially after dialysis. Repeat cultures is still showing the same Klebsiella low. It's an ESBL. The patient now is on NORAD, even though his TLC has come down, it's 21, but his CRP is 258. That's bad. CRP, anything more than 200 is extremely bad. So what do you do? What do you do? What do you do? You can increase the meropenem dose. You can go for an aortic valve replacement. You can remove the dialysis line, or you can put in an antibiotic lock solution. What would you say? Lock therapy. Look now. Give me now. Some people say remove the line. Some people say the numbers. D. Those want to claim what is the lock therapy? That's a good question. I'll tell you what is the lock therapy. Lock therapy means you put in an antibiotic inside the catheter line. So the dialysis catheter is there, right? It comes out like this or like this somewhere or in the groin. So in that, you're thinking that is infected, right? So you put in an antibiotic right there and leave it like that. So that's the option. That's what the lock solution is. Okay, now that I have explained that, Nikita and many others want the lock solution, but some, Anshu, Krishma, and a lot of others, they want to use the lock solutions also. Okay, what do I want to do? No, please remove the dialysis line, okay? I just put in a fancy thing in there and a lot of people want to do this. They come up with new concepts all the time, right? And then they're like, oh, this is cool, so we can do that. But don't do all these cool things. Just think through the basics. Okay, the line is infected. You know the line is infected. The line's been there for 2 years now. It's been too long. You got to remove that line. Okay, that's not going to work anymore. Better remove that line. It's going to die. Now, still, case is going on. This is like an IPL match now. What antibiotic duration will you give? This is an endocarditis question. So how long will you give antibiotics? Until the cultures are negative, until the valve surgery, until clinically stable, or until TLC and CRP is normal, or 4 to 6 weeks based upon everything? What do you want to do? Options. A lot of people want E, some people want until CRP better, ED. Some people have come up with C, D, E. What do you think? Almost 8:30 now. We don't have time. Come on, people. Bhargavi says E. Asha says D. Until CRP better. Sini says E. Sagrika says E. Okay. My response. You want to see my response? My response is also E. Good for you guys. All the E's, you got it right. Why E? Okay. Just because the blood cultures are negative does not mean the infection is gone. Actually, the culture, once the cultures turn negative, that is when the duration starts. So that is not when you stop the antibiotics, that's when you start the antibiotics. Until the valve surgery, no, you don't. What if the valve surgery is not even required? You don't do that, right? Or if the valve surgery is required too soon, you don't still stop it. Not until clinically stable. Patient might get better in 1 week. Infection is not going to go away. TLC and CRP might also get better pretty fast. You don't stop it until then. Usually you consider all of those things and at least give 4 to 6 weeks. Okay, case 4. Try to move fast. We are coming into the last 5 hours now. 67-year-old female. Again, CKD patient, malnourished, diabetic. She's admitted for melena, diarrhea, weakness, and she does not have any fever initially. But then when we checked her vitals, she said she has no fever. But when we checked her, her temperature was 1 or 2. Heart rate is slightly high, BP is slightly low, hemoglobin is low, TLC is 24, creatinine is high. She is a CKD patient. His creatinine is slightly higher than her baseline. Albumin is low. CRP is very high. Procalcitonin is less at 0.1. Endoscopy shows some gastritis. Colonoscopy is normal. So see, you're complaining of melena and diarrhea, right? And endoscopy, colonoscopy is normal. Blood culture is negative. Patient is on meropenem and teicoplanin, still having fever. Counts are high. CRP is gone up to 290. Earlier, CRP 223, TLC 24. Now, TLC 21. TLC has come down, but CRP has gone up, and beta D glucan is also positive. So, what do you do now? Some others are also talking. If you can just mute your devices, sometimes unknowingly you might put it on. So if you can mute it, we'll talk. So what do you do here? You have 4 options. Okay, you can add tigecycline, add colistin, or fluconazole, or micafungin. Which one is your choice? Fluconazole, D. Grishma says D. Yalto says C. Sonia says C. Vinny says C. Add colistin. Mohammed Abshal says C. Fluconazole. I'm getting a lot of fluconazole. I guess you'll like fluconazole. Huh? Somebody says micafungin. Switch to antifungal. What antifungal? Somebody says colistin. Procal is 0.1. So no need of antibiotics. So what else do you need? Should we stop everything? CA. Okay. Okay. Sorry, actually I didn't put the answer the thing there. But the answer is D. Okay. It is micafungin. The reason being, beta D glucan is positive. That means the patient is having a candida infection in the blood. Okay. It doesn't fully differentiate between other things also, but most likely it is a candida infection because also the procalcitonin is negative. So probably less likely to be bacterial, and patient is having a lot of fever and not responding to a broad spectrum antibiotics. Right? We have given broad spectrum meropenem teicoplanin and still not getting better. So gram positive, gram negative, not getting better. Okay. So maybe micafungin. Case 5. We'll try to finish this first fast. Neurosurgery patient who's had some brain surgery because of a stroke, something, and now he's on a T-piece. Do you understand a T-piece? It looks like this. That is a T, right? So it is put like that, and then looks like this. It looks like a T, right? Whatever. And then it's put onto oxygen. He's having no cough, no shortness of breath, but he's having some fevers. Blood pressure is stable, TLC is normal, Procal is okay, and the ET you have sent off, and now is showing you a bad bug. MDR Acinetobacter. You don't like those MDR Acinetobacters, right? It's a bad bug. It's sensitive to TG, minocycline, intermediate to colistin, resistant to everything else. So what antibiotic would you want to choose now? Okay, people, fast. Type in your responses. You can see the responses. Colistin, TG, amikacin, ceftazimab, aztreonam, nothing. Somebody says nothing. Somebody says A, B, C, D. I've got all of them. Somebody gives options which are not there. Okay, come on. You cannot give options. I am the one making the options here. You cannot make the options. Repeat the question. What antibiotic you can give? Okay, that is the question. I don't know which is the most dominant one. I think most people are saying nothing. Aisha says nothing. Anna says TG. Doctor says something. Akshara says B. Fennel says colistin. There are some questions about the previous ones too, but I cannot get into those. Nothing. Here, the patient has central fever. What is a central fever? Central fever is something that comes from the brain. You have a neurosurgery patient after a stroke, after some brain insult. many people's temperature regulation center is gone bad. Okay, like we say mental, right? So this part of the brain has gone, the fever center has gone mental. So that center is unable to tell you what temperature to maintain on the body. So it always goes up and it goes down, and it's crazy. Why do we think like that? Because the patient is clinically stable otherwise. Very minimal tracheal secretions, breathing is fine, blood pressure is fine, chest X-ray is normal, WBC count is normal, procal is normal, everything is normal except for culture, which is positive. In this situation, culture should have not even been sent. Okay, but you do all the other routine stuff. Okay, you should do a blood culture and you should do all the labs, make sure that patient is not having an infection. If the patient is not having anything, then the patient does not need anything. Why give an antibiotic if there is no infection, right? There's no point in giving infection. So that's the reasoning. Understood? Got two more cases. We'll try to finish that off as soon as we can. 69-year-old diabetes, hypertension. She's in the bed, bedbound. She's got a bed sore, no fevers, urine culture. She's bedbound, right? So she cannot even get up. And so the family requested and they put in a Foley catheter now. And now it's showing a Candida tropicalis. So this is a fungal infection that we're talking about. We've done a lot of antibiotics, bacteria, we did, antifungal. Also, now we're talking about Candida tropicalis, which is sensitive to everything. Fluconazole, voriconazole, micafungin, amphotericin. So what antibiotic would you want to start? A, B, C, D, E. You cannot see those options very well, but hey, you can type anything. What do you want to type? Fluconazole, or amphotericin, fluconazole, amphotericin, none of the above. Subfolate, none. D, ampho, none. E, ampho, E, D, B, A, C, B. Very few have said B. Most have said fluconazole or amphotericin or Demanix is off Foley, remove Foley. Okay, we cannot do that. The patient is bedbound, unable to go, it's got a bed sore, right? If you take off the Foley catheter in a bed sore patient, you're going to maybe in trouble. But unless you are a very good worker and you can keep cleaning the patient very well. What would I do? Okay, micafungin. No, that's not a good choice. So these are three different classes of antifungals here. The azole ones, which is fluconazole, which is good for Candida UTIs. And anidolafungin and micafungin are echinocandins, which are not good for UTIs or pyelonephritis. Amphotericin also is really not a good choice. Actually, the patient doesn't have anything. Patient is having a colonization. See the patient's thing. There is no fever. There is no TLC elevation. CRP is not high. Patient is fine. Why do you want to treat a fine patient? Don't treat anything. Okay, nothing. This is my last case and I will be done with this. Okay, please hang in there. 4-year-old young girl, a pediatric patient. So I just wanted to bring in a different side. A 4-year-old girl is having, who's 12 kgs, by the way, having fever, cough, cold for 3 days. And still, when you see her, it's still having fevers, 101, heart rate is slightly high, saturation is fine. She's not eating much. She's having an occasional vomiting. So these are the medications she has been started on. Syrup, paracetamol, azithromycin, and Zincovit. Next day, the parents bring her back to you. She's still having fever, cough, cold. Now she's even eating even less. She's becoming more weak. She's having more vomiting. And she's also having diarrhea. She's hardly eating anything, just some curd rice, some peanut butter, and ORS. She likes peanut butter. The parents like curd rice and ORS. So, what should you do? What do you want to do? 5 options again. Okay. Continue same, which means continue paracetamol, azithromycin, and Zincovit, or stop azithromycin and change it to amoxiclav, or stop all of them and add ondansetron. Stop azithromycin, change it to an injection formulation, so you can give IV instead of orals now. Also, continue azithromycin, but add loperamide. Along with that, add peptaz, piperacillin tazobactam. What would you do? What would you do? Last one, please. Come on, let's finish it off well. A, E, D, C, E, C, D, Gino says D, Manisha says C. Because diarrhea is there, somebody says don't give augmentin. Last, Anjali says C, Safiya says C. Karthik says E. Okay, so my answer, want to see my answer? My answer is actually C. I didn't put that on also, but answer is C. Patient did not need antibiotics. Why did the patient get antibiotics to begin with? This is a viral fever. You have cough, cold, fever. Majority, 95 or 99% of the time, this is a viral fever. You're giving an antibiotic for this and zinc COVID, you're only going to make the patient worse. Patient is not going to eat anything. It's going to get more tired. So this is the classic reasons what people do for children. And this is how you're inducing resistance from young age, from children. Parents are all worried, oh, my child, you know, they need some antibiotics and they run. And many of you pharmacists, you're also to blame. You just give those antibiotics to the patient just like that. Please don't do that. You may have children of your own or your sister or somebody's children, and you're like, somebody will ask you and they're like, yeah, sure, give azithromycin. That, like, you know, in Telugu, we call it Sarva Roga Nivarni, which means it will cure everything. No, it doesn't. Okay, you don't use antibiotics like that. Think through it and then use it. Okay. Don't give other antibiotics. Patient does not need any other antibiotics. So that's the only one option that I've given is C, which is to stop antibiotics. Even don't give zinc COVID. That's also actually going to cause more irritation in the stomach. So stop everything. Okay, done. I'm done. There are a lot of
Sir,
other
how
situations, but
to
we are not
treat
going
the
to get
diarrhea, sir?
the diarrhea. The ondansetron will take care of it. The diarrhea is because of the antibiotics, actually. It's because of the azithromycin and the zinc COVID probably is causing the diarrhea. The diarrhea was not there until you started these medications. So this is a classic example of creating a problem which wasn't there and trying to give something even worse to clear that problem. Thank you. I'm going to be done.
Okay, sir. Thank you, sir.
Thank you very much, Dr. Ravikiran, sir, for taking time out for from your busy schedule. The case study was really informative and we enjoyed the interactive sessions too. Now it's time for the question and answers, and I have noted few questions. A patient is 45-year-old female complaining of cough since 1 month, mild history of knee osteoarthritis, chest x-ray was completely normal. In blood reports, ESR was 42, HB 9, and RBC counts was 3 lakh. Doctor prescribed folate agents, cough syrup, doxycycline, and cefpodoxime plus clavulanic acid. Is this rational? If not, what could be the therapy? So if you're kind
No,
enough
I
to
don't think
answer
it's a
this.
rational choice at all. I think the patient has probably some allergic cough or some post-viral or some post-infectious cough that is still lingering around for some more time. Patient does not have any fever. The lab markers are not at all bad. Chest x-ray does not show anything else. There is no need for antibiotic at this point. It looks like the patient got 2 antibiotics, not just 1. So it's completely unnecessary. It is like that child who was given antibiotics, which was not necessary. Now this patient will also complain of weakness, tiredness, nausea, and diarrhea. All of those are antibiotic associated. This is a classic case of how not to use antibiotics.
Okay, thank you, sir. We have one more question. If a patient is prescribed with cephalosporins and given 2 days, and it is changed to penicillin like piperacillin, and due to a change into another doctor, So whether this is rational, or do we have to check for factors for changing before changing?
It's okay to change. We change antibiotics quite frequently. We have to think through what the patient has, what are we trying to treat. In certain situations, we do change over. But if you're thinking the bacteria was resistant to the first antibiotic and now it is sensitive to the new antibiotic, then the duration starts from the new antibiotic day. You cannot count the old. Let's say you gave 3 days before. Now we cannot say, okay, I'll just take 2 more days and 5 days you're done. It doesn't work like that. So from that point, you give for another 5 days, if that is the appropriate situation.
Okay, okay. Sir, here is one question. Recent guidelines suggest that Acinetobacter should not be considered as opportunistic pathogen or colonizer and need to be treated with empirical antibiotic along with the source control. May I know what about your opinion?
No, that's not true. I don't know where you got that, but we see Acinetobacter many times, okay? And it is not necessarily a colonizer, but it suggests poor infection control principles. Because it's not normally present in the body, but it can be transmitted in the hospital. It may not necessarily be the pathogen. If the patient is just having a bacteria, whether Acinetobacter or something else, you just don't have to treat that. You have to put everything into the picture, and that's why, most of you, we call them as clinical pharmacists. You have to think through the scenario and say, well, is this an appropriate scenario? Is this an infection first? If it is not an infection, then don't worry about everything else.
Okay, okay, sir. Hereby, it looks like we have covered everything before we wind up. And now you can here in chat box you can download the e-certificate will be provided later, but now you can fill the feedback forms. So by that you can get your certificates. And now it's time for the vote of thanks. It's my pleasure to welcome Dr. Saju Samuel, Head of Medical Service, Apollo Edlex Hospital, Angamali, for the vote of thanks. So, Saju sir, over to you.
Thank you, Sri Lakshmi, and good evening to all. Actually, it was a pleasure just listening in the evening to both the speakers, like Dr. Vishnu and Dr. Ravikiran. Both of them have done a wonderful job, and congratulations to both of you. And again, thank you from Apollo Adlux Management and our medical fraternity for chipping in and sharing your knowledge. Again, thank you, Dr. Vishnu and Dr. Ravikiran. A big round of applause for them. And now I would like to thank our team clinical pharmacy in Apollo, headed by Dr. Noble Skaria, and ably assisted by Sri Lakshmi and the other colleagues, Stelvin, Julie, Sarah, and all those people. You are doing a wonderful job, and congratulations to you also for arranging CME, and which I can see has been well attended. 500, 600 plus delegates. So that is a good show. Congratulations to all of you. And again, thank you for that. And again, thank you to all the delegates who on a working day have found time to log in. And as we all know that knowledge is always enhanced by sharing. It's just like lighting a candle. The more lights more candles you light, it's a more brightness. It's that when you share your knowledge with somebody, it's not that you lose your knowledge, it become enhanced. So similarly, more of CMEs, more of knowledge sharing platforms will always be helpful, both for the person who is presenting the case as well as for the person who is listening. So congratulations to the entire team. A good work done. Again, special thanks to Dr. Vishnu and Dr. Ravikiran. Thank you, Dr. Noble. A good show by Sri Lakshmi also hosting the show. We will have more events like this in future. Apollo Adlex Management is committed to propagating the healthcare as well as health education. So we will be glad to help in further such events to increase and propagate the knowledge of medicine. Thank you all, and have a great evening ahead. Over to you, Sri Lakshmi and Dr. Noble.
Thank you all for your wonderful support. And we will be coming up with future webinars related to antibiotic stewardship and all. And we have so many eminent speakers with us. And once again, thanking Dr. Ravikiran sir and Dr. Vishnu because you have done a great job. Because so many are eager to wait for this kind of topics and all. In future also, we will be conducting these programs. So any other questions we can within 2 minutes we can wind up.
Sir, how to alter the dose in the CKD conditions? So there are 6 stages of CKD. In that stage, how do we alter the antibiotic dose, sir? So can you please explain something about that?
You can answer that. Vishnu there? Maybe Vishnu is gone. Maybe I'll only tell. So it depends upon your creatinine clearance, right? You have to calculate your creatinine clearance. If the creatinine, based upon the creatinine clearance, you adjust the dose. Some antibiotics don't need any dose adjustments, regardless of the creatinine clearance, like rifampicin is there, right? Isoniazid. They don't need any dose adjustments. Versus the Tambutol, pyrazinamide, meropenem, all of those, and most other antibiotics will need dose adjustments. And if patient is on dialysis, definitely there is a lot more dose adjustments that have to be done. And the dose has to be given after the dialysis, on the days of the dialysis.
Any more questions from the audience?
Okay, I think I'm going to stop also. I'm going to leave. It's getting late for everybody also.
Yes, sir. It's a time. Can.
Yeah, so I'll also check out. Thank you, Nabil and Sri Lakshmi, for this great program. Enjoyed it. We'll do it again sometime.
Okay, sir. Thank you.
Yes, sure.
Thank you, everybody, for coming. Thank you. Bye-bye. Good night, everyone.
Okay.
Good night.